The purpose of this presentation is to share my idea and technique to the dentist and the dental technicians about restoration of the implant. The Straumann tapered bone level implant is used. After waiting for 4 months for integration of the implant, the impression coping is screwed in and a purple plastic cap is snapped on. Photo 2. The internal surface of the impression with the purple cap came out with the impression. Photo 3. The impression coping from the mouth is screwed into the implant analog. Photo 4. The assembly is snapped into the purple plastic cap. The soft pink gingiva, which is removable, is filled up to implant margin, the pink band. The impression is boxed and the die stone is poured. Photo 5 is working cast with impression coping. Photo 6, the mounting the cast. Notice a space between two antagonists is inaccuracy in mounting the cast. This caused a lot of trouble in the occlusion in the later procedure. This presentation will solve the problem. Photo 7. UCLA abutment is placed in place of impression coping. Photo 8. The tube is cut down to 1 millimeter short of the antagonist. Photo 9. A ball is inserted into the tube to prevent wax from entering into the hole. After removal of the soft, flexible gingiva, the impression margin is exposed for instrumentation. Photo 10. The gingival 1/2 of the wax pattern is over-contoured to reduce gingival embrasure and provide emerging profile in the mouth. But neck area of the wax up should be slandered so as not to impinge the gingiva. Photo 11. The occlusal surface should be shy about 0.7 millimeter for building up the occlusal contact in the mouth in the later procedure. Photo 12. The wax pattern is hand tightened. Baby powder is applied to check the clearance. Notice tissue impinging on neck area of the wax pattern should be shaved. The tissue impinging may cause tissue necrosis. Photo 13. Remove the pattern from the mouth and add the proximal contacts with red soft wax. Place the pattern back into the mouth and tighten. Then the contact would be like this in the photo. Photo 14. In the same way, the occlusal contacts are added with electric waxer and red soft wax in the mouth. There are about 8 occlusal contacts in this 60 years old patient on mandibular, first molar. These contacts are 2 marginal ridge contacts. One is a medial marginal ridge and the other is a distal marginal ridge. There are 4 triangular ridge contacts. The one is the facial triangular ridge of distal lingual cusp, which is shown on the photo, 2 millimeter in diameter indentation. The heaviest mark on the photo. It named facial triangular ridge because it runs toward the facial from the lingual cusp. You see the lingual triangular ridge of major facial cusp shown with an arrow point. But there one triangular ridge is missing due to large screw hole in the center. That is a lingual triangular ridge of distal facial cusp. There are 3 cusp contacts. These are major facial cusp and distal facial cusp and the distal cusp, which are working cusp. There can be cusp ridges which run major distally from the facial cusp tip, but it is too much to describe in this presentation. The wax is the best material for the fine artwork. Photo 15. The casting. We must be very careful about 2 factors. The one is porosity. The other is bubble in the tube. The porosity. When we cast thick crown like implant crown, the gold shrink and leave lots of porosities. To prevent this, we must put a reservoir which is the same size or even bigger than the crown. The other bubble in the tube. To prevent this, we must fill the tube with investment. Otherwise, metal goes into the tube, jeopardize the work. To prevent this, we place investment in the tube, or we maybe put latch type into the tube, or we can find pencil lead, which is 2.3 millimeter in diameter, and insert pencil lead before investing. Another thing, we have to put a tube more horizontally than vertically, because investment may flow out of the tube. Photo 16. The crown contact is checked in the mouth while the articulating paper is being inserted into the proximal space. The patient should feel nice and tight contact. The gold alloy shrink about 1.2% during solidification in casting procedure. The investment expand about 0.01% more to compensate for the metal shrinkage. This makes the contact nice and tight. Photo 17. The contacts are smoothed with a rubber wheel. Notice the center is not touched. One of the factors which is good in natural dentition is that the teeth migrate mesially to compensate the wear of proximal contacts. The implant crown does not migrate. There would be mesial space developed on the implant over time. This is one of the reasons an implant crown is not as good as natural teeth. Photo 18. Notice the red occlusal contact on the triangular ridge of distal lingual cusp is being narrowed during waxing and smoothing the crown. I think smaller contact is better in chewing tougher meat. I don't think machined crown is as good as a waxed crown. Photo 19. The neck area should be slandered and highly polished. Photo 20. The crown is hand tightened and the screw head is covered with Teflon tape of 5 to 7 centimeter and leave 2 millimeter depth for composite resin. After curing the resin, the patient is dismissed for a few weeks. If there is no problem after that, the crown is tightened permanently with torque wrench to 35 Newton centimeter. Photo 22. Natural dentition move during chewing resulted in contact wear and contact missing. In order to compensate this, natural dentition move mesially, so-called mesial migration. On the other hand, implant crown, the first molar doesn't move. That creates space between distal surface of second premolar natural tooth and mesial surface of implant crown. If that happens in several years, the crown is removed and soldered and replaced. The end.